another subgroup which you might find in some of the literature, and that includes a separate group for congenital skull-based defects and subsequent CSF leaks. And as you can see in the images, these are actually images very kindly loaned to me by Professor Darlene Libber of her actual patients and kind of the broad spectrum that she's seen. So these are actually patients that she's managed. So on the left, we have iatrogenic, in the middle, we've got traumatic examples, and then that was a spontaneous CSF leak as a result of that large tumor. If we look at the etiology and we're looking at these four nice broad categories, the first point to discuss are these iatrogenic CSF leaks. Now, these are caused by us as surgeons or neurosurgeons, and really it happens when there's surgical manipulation right near the skull base. The injuries can really vary. They can either be simple cracks, or you can accidentally cause very large defects. That would be around about more than 1 centimeter. From a neurosurgical perspective, it could be caused by craniotomies, and then areas that we are very actively involved in, for example, your transsphenoidal pituitary resections, or any other approaches for neuroplastic disease from neurosurgical perspective. And then us as ENTs, apart from the transsphenoidal pituitary resections, when we do our functional endoscopic sinus surgery, there really are 2 points of potential iatrogenic injury specifically. I mean, there are many, but these are 2 worth mentioning. The first one is that area of the lateral lamella of the cribriform. And the second area of interest is the area of posterior fovea ethmoidalis, or the posterior aspect of that frontal recess. Other surgeries which can result in CSF leak are your septoplasties, and obviously approaches for our neoplastic disease, such as our sinonasal tumors. Now, what is interesting is that around 50% of iatrogenic CSF leaks will present in the first week after surgery. So only half the patients that we've caused a CSF leak in will be evident in the first week. That means that the other half are already discharged. So you will need to counsel your patients very extensively on the symptoms so that they know what to look out for. For example, things like salty or metallic tastes in the mouth. Iatrogenic leaks we can see in pituitary surgery, as in this example. So when we're doing pituitary surgery, we really need to always be prepared for a CSF leak. You've got to prepare the abdomen for some fat harvesting in case you need to repair this leak. And you also want to prepare a unilateral mucoperichondral septal flap. And that can be done by using this area. So this is an image of pituitary surgery where you can see that there is, in fact, quite a significant CSF leak. So we'll just let the video run for a few minutes, but perhaps you can just gain the impression that there's a bit of leak coming from that area. So iatrogenic CSF leaks, obviously they can occur during surgery. If they're diagnosed intraoperatively, you really have to try and repair that immediately. In these instances, you can use intranasal tissue, partly because it's readily available, because you're using an endoscopic approach. And then there are other areas, specific areas which maybe we've touched on, but specific areas that are related to the surgery, which may be prone to injury. That lateral lamella of the cribriform plate, that's around 40% of cases. There could be a defect in the frontal sinus, 15% of cases, and then your sella tunica and sphenoid sinus involvement. When we look more specifically at endoscopic sinus surgery sites of injury, that's the lateral lamellar cribriform plate and that posterior ethmoidal roof right near the anterior and medial sphenoid wall. If we move on to the traumatic group of CSF leaks, these really form the bulk. So these are around 90% of CSF leaks. The majority of these are blunt, but you can have penetrating trauma causing traumatic CSF leaks. They are really divided into 2 groups. So they're divided, traumatic CSF leaks are divided into immediate, that classifies as within 48 hours. And that's by far the majority of CSF leaks. There you might be able to see a bony defect and get an impression of a dural tear. As evident, often these patients come with CT imaging, as referred by our neurosurgical colleagues. Or you can have the group that's a bit more delayed. Now, around 95% of patients with delayed traumatic leaks will present within about 3 months after the injury. And the delayed theories are twofold. So the first theory for a delayed traumatic CSF leak is that previously you actually had intact dura, and slowly with time there was a herniation through the bony defect. Finally, it resulted in a tear, and that is then when you see the CSF leak. The other theory for delayed traumatic CSF leak is that actually the tear and the bony defect is actually there at the time of injury, but the leak only really becomes evident when that overlying hematoma, which is covering it, begins to dissolve. Now, traumatic CSF leaks, by far most will heal purely with conservative management. When they heal, you often have a sinus mucosal layer of defect that begins to close. Now, we know that the dura will not close itself because it won't regenerate itself. So there is a question in the literature as to whether or not there's a relative fragile closure because you've only got a mono layer of mucosal protection. And that might give you a continuing risk of meningitis. So considering that there's relatively small risks of endoscopic surgery, it does beg the question whether or not perhaps we should be taking a more active interventional policy, even when it comes to CSF traumatic leaks, if there's a small possibility that there might be a continuing risk for meningitis with this fragile mucosal layer closure. In patients with massive head trauma, there is room to consider that perhaps this might be better to do with an open approach, but these are generally in patients where the other significant intracranial injuries actually need surgery. So this is where the neurosurgeons might take this patient for surgery because he's got significant intracranial injuries. And then you could opt for an open procedure to repair any evident CSF leaks at the same setting. The third group is our spontaneous CSF leaks, also known as idiopathic. Now, we know that the dura is subject to really wide CSF pressure variations, and our spontaneous CSF leaks really are most evident in our middle-aged females. As we grow older, there is a relative increase in CSF pressures. These are patients that have increased BMI, and there's quite a strong association with obstructive sleep apnea. There was a study done by Lober et al. That showed that patients that had spontaneous CSF leaks in this study, up to 72% were female, and 45% of them had OSA. So it's quite strong associations. And it's thought that these leaks are really variants of benign intracranial hypertension. It might be because in these patients, there's poor CSF reabsorption by your arachnoid villi. Now, because of this raised intracranial pressure, with time, you get that bony thinning into the weakest areas. And then there's this herniation. And herniation can occur at the lateral lamella of the cribriform or the lateral recess of the sphenoid sinus. But what's important to know is that with spontaneous CSF leaks in patients with benign intracranial hypertension, they can actually have multiple weak spots. And although fluorescein is not routinely used at our center, the literature does suggest that perhaps this is an area where fluorescein can be used when you have multiple weak spots to actually identify one particular area of active leakage, rather than having all these weak spots and you're not really sure where the CSF leak is coming from. There was a study done by Lieberman that showed that in these patients, there was actually a significant increase, and a lot of them had multiple skin-based defects. They found this in around 8 out of 44 patients. And the question is whether intracranial hypertension can put these patients at risk for developing these defects. So in contrast to traumatic leaks, spontaneous leaks are most likely out of all the leaks to actually reoccur. So the success rates for endoscopic procedures are worse than in relation to the endoscopic procedures for other pathologies of CSF leak. So you can have a re-leak at the repair site, or as mentioned, you can have it in multiple areas of weakness in the skull base. So it's really important that that elevated intracranial pressure needs to be treated. And this is where some studies recommend acetylazide. And in very selective patients, you might need VP shunting. But because there are areas of substantial skull-based dehiscence, you may consider that some of these patients might benefit from reinforcement at the time of CSF leak repair using grafts such as bone or even cartilage. If there's a leak in the lateral recess of the sphenoid sinus, then you may also consider an approach, transanteriorly transpterygoid approach, in order to be able to access that sphenoid sinus. Our final group is our congenital leaks. Congenital leaks can be as a result of skull-based defects or even tumors. It could be an embryological defect, congenital CSF leaks with encephalocele or meningeal cells are actually uncommon, but you should always have a high index of suspicion in any pediatric patient with an intranasal mass. You have to have this high index of suspicion, and in these particular patients, you may want to delay the biopsy until you've got some further imaging. The imaging that you may require is an MRI. And on the MRI, you might see a bit of a sinus opacity right next to an area where you can actually see a skull-based defect. And that might give you a clue that this is in fact an encephalocele or a meningoencephalocele. The tissue in this encephalocele is non-functioning. So during surgery, this can be removed. Tumor-related CSF leaks. Our benign tumors don't commonly result in CSF leaks, but your aggressive ones like inverting papillomas, they can erode the anterior cranial fossa and result in enzymic breakdown of the bony architecture. Typically, when we try to resect these aggressive lesions, that can result in leakage at the time of resection. Sometimes patients that have received chemotherapy causing the tumor to shrink, they can also present with a CSF leak. But at the time of doing a surgery and repairing the CSF leak or removing these aggressive lesions, it's very important that you actually clear the margins. The margins need to be completely clear of tumor, because to come back and try and address it again is extremely difficult. So how do we manage CSF rhinorrhea? Well, it really depends on the natural history of the leak, and that's very highly dependent on the etiology. So the previous 4 groups that we've discussed, each of them have their own sort of natural history. It's also going to depend on where the leak is and how bad and significant the leak is. And for all of this, we really need good clinical assessment. So for clinical assessment on history, you might have clear, watery, unilateral discharge. Obviously, you want to ask them if they've got a history of trauma or surgery. Those delayed fistulas are a lot more difficult to diagnose because they can actually occur years later, and you might have misdiagnoses of patients having had previous diagnosis of allergic rhinitis. Sometimes patients can complain of headaches, and they may have had a CSF drainage before that made them feel better. You might have an intermittent leak. In other words, not a leak that happens consistently. This is actually called a reservoir sign. So the CSF fluid collects in a paranasal sinus, and then as soon as the head position changes, it then begins to drain externally. So you get a bit more fluid coming out as soon as the head position changes. You always want to ask about signs of raised intracranial pressure, so symptoms of headache and visual changes. You want to know, has this patient had meningitis before? Is this the second time it's happened, just to give you an indication? And then there might be some localizing symptoms related to anosmia, where there might be injury to the olfactory area. And obviously your optic nerve deficits might give you an indication that perhaps there's sphenoid sinus involvement. On our physical exam, you're obviously going to do full rhinological, including endoscopic examination. You're going to check the ears, head and neck, and do a neurological examination. When you do an endoscopic evaluation, you can ask the patient to Valsalva and see if that produces a leak that is evident. There's also a Quenkenstead-Stuckey test where you compress the jugular veins, and that might also produce a CSF leak. There's a couple of bedside examinations and bedside management principles. Often we have these patients that have very significant head injuries, and this actually makes the diagnosis of a CSF leak pretty tricky. There's often a mixture of blood and CSF. And in the literature, there is the halo or the double ring sign that has been described. But what is important to know is that it's not exclusive to CSF. So it can be a false positive. So it's not to rely on a double halo or ring sign. You can actually have bilateral CSF leak. And this actually occurs when those midline structures are dislocated. So the CSF is actually allowed to flow to the opposite side. But by far the most common clinical findings associated with CSF rhinorrhea are meningitis in up to 30% of patients, and actually pneumocephalus in up to a further 30% of patients. What lab studies can we do? Well, There are a few. The first one is glucose content, but this is really unreliable. It's quick, but it's really unreliable, and it's not recommended for screening or confirmatory tests. It gives you a lot of false positive results. In your nasal mucus, you can have reducing substances, which can give you that false positive result. If your serum glucose levels are very high, it will also give you a false positive result. If you've got active meningitis, your glucose levels might be slightly lower. That'll give you a false negative. And it doesn't tell you anything about where the site of the leak is or even what the size of the leak is. So glucose content, not very good. It's a quick test, but it's really unreliable. The second one we can look at is beta trace protein. This is good. It's got sensitivity of 92%, specificity of 100%. The only thing to note about this is that it can be altered in other things like renal failure, cerebral infarction, or cranial nerve tumors, but not a bad option, but it's not really specific for site or size of the CSF leak. Then beta-2 transferrin. So currently this is the single best lab test because it's only located in CSF, perilymph, and aqueous humor. So it's highly sensitive, highly specific, it's rapid, it's non-invasive. You only need about 0.5 mils required for electrophoresis. It can actually stay stable at room temperature for up to 4 hours. So your patient, if they're collecting it at home, can collect it and they can actually put it in the fridge, but the specimen should not be frozen. The only drawback is that it doesn't really give you information about the site of the defect, and you have some center testing restrictions. Sometimes we need to transport these lab specimens to other centers, and that obviously can add to a delay in diagnosis. Imaging studies, CT high resolution is by far the imaging modality of choice. It can show you where the skull base defect is, it can show you any other anatomic abnormalities, and it can give you an impression of an erosive lesion. You might see a bit of pneumocephalus, and that really should make you think that it might be a dural tear. If you see an air fluid level in one of the sinuses, it could be CSF, but it's not diagnostic. So it could also be other causes of that air fluid level. CT scan, just to be aware, can also identify inactive defects. In other words, you might see other defects in the skull base that actually aren't actively discharging CSF. With regards to CT scans, we often use the coronal, but we like to MPR, and the other views are also helpful in assessing the imaging of the patient. We can do MRIs, but they're typically not our first line. Where they are helpful is, as we mentioned before, if you have an opaque area, that's an opaque sinus area that's just adjacent to a skull base defect that you can see on the CT scan or the MRI, you might think that maybe there's an encephalocele. MRI, it's time consuming, it's pretty costly, it's not readily available at all centers. You might need some contrast, and it may not necessarily be localizing. The literature also describes cysternography. For cysternography on MR, we don't really need intrathecal contrast. It's a T2 weighted imaging, but it can possibly give you a false negative if there's an intermittent CSF leak. CT cysternography, this is where they actually inject intrathecal contrast, and it will help you to identify a leak if it's active. It might give you a false negative if your leak is sort of intermittent and it doesn't see it at the time of doing the cysternography. It's pretty invasive, and you can have some side effects to the intrathecal contrast, like GIT upset. And then the last imaging modality that the literature describes is you can have different kinds of nuclear medicine radioactive isotopes. They are administered by lumbar puncture, and then they do serial scanning. They also describe cutting little pledgets into different shapes and placing them in different areas. And then these pledgets are analyzed to see if this radioactive nucleotide tracer has marked that specific pledget. And you're supposed to remember the kind of shape that you cut the pledget in so that you know where it came from. But, you know, with these isotopes, there is systemic absorption. 33% false positives and kind of unreliable borderline readings, so maybe not as good. There are some diagnostic procedures you can do. Certainly this is not practice at Groote Schuur Hospital, but the literature does describe intrathecal fluorescein. Diagnostically, fluorescein can be used to localize sites of the leak, but it's not FDA approved. You can use a lumbar puncture and or a lumbar drain to administer it. And how they do it is they withdraw 10 milliliters of CSF in a sterile manner. They then take 0.1 mil of a 10% fluorescein solution. They dilute it in that 10 mils of CSF. That whole mixture is then re-injected very slowly into the subarachnoid space over 10 minutes. And you have to give it very slowly because then it actually reduces your rate of seizures. Now, once you've injected it, it might be visible with a xenon light source intraoperatively. And there's also some blue light filters that you can use if you think the leak is very small and you feel that the blue light might be able to pick up the fluorescein a little bit better. So if we look at our indications, which are the patients that we need to surgically repair and which are the patients that we need to manage conservatively? So all patients with spontaneous CSF leaks should be considered for repair. If you have patients that intraoperatively you've caused an iatrogenic leak, you should repair that iatrogenic leak immediately. If a patient does not present with if during the surgery, the patient does not have an iatrogenic leak, but the leak after surgery happens within a week or so, that is also indication for a surgical repair. Trauma is really this one group where conservative management is a good option, and conservative management duration for trauma is around 7 to 10 days. If it persists after that, or if you think there's a very large defect, that can then be considered for surgical repair. And of all these things, the biggest risk is meningitis if the CSF leaks are not repaired. So what is the actual meningitis risk in terms of numbers? Well, if you have an active leak, your risk of getting meningitis is 10% year on year. There's a more recent study which actually says that it's 0.3% for every active leak you have per person. The most common organisms are Streptococcus pneumonia, Haemophilus influenza. And in your first 3 weeks after trauma, you have about a 10% chance of getting a CSF leak. That rate increases significantly to 40% in those non-traumatic group of CSF rhinorrhea. So what does conservative management actually look like? As we mentioned, this is a group that's sort of reserved for traumatic cases, and it's advocated in that immediate onset leak group. The reason is that there's quite a high likelihood of spontaneous resolution. So you're going to give this patient 7 to 10 days of bed rest. You're going to elevate the head of the bed 15 to 30 degrees. You'll give them stool softeners. You'll counsel them not to blow, cough, strain. So those are really the foundation principles of conservative trauma management. The literature does describe and question whether or not you should be considering a subarachnoid lumbar drain. As I mentioned before, this is not practiced at Groote Hospital, and these lumbar drains have not actually been statistically shown to decrease recurrence rate of CSF leaks. But if you are going to put a drain in, then in essence, you should drain around about 5 mils of CSF every hour, and you should do continuous drainage rather than intermittent so that you avoid those spikes in the CSF pressure. So with regards to, with regards to leakage stops, so almost 70% will stop within a week, and then 20% will stop within 3 months. And in 6 months, most patients' CSF leaks will have resolved. The leak almost never recurs in traumatic patients versus the non-traumatic patients where only, where there is a very high risk of CSF recurrence. And that risk stays quite high for a period of about 7 years. When we talk about antibiotics, there is no conclusive evidence on using showing that prophylactic antibiotics will reduce your meningitis risk. Previous studies on the use of antibiotics as a conservative option showed mixed results. The one place where we think that endoscopic sinus surgery to address CSF leaks is reasonable is when you're actually taking this patient to surgery. So it is reasonable to give an antibiotic dose. but there are no randomized control trials. And the assumption of giving the antibiotics as an intraoperative dose or preoperative dose is because a lot of the patients that are undergoing surgery actually already have underlying inflammation or infectious pathology. Should we be considering diuretics, acetylizidamide, in conservative management? The assumption is that it reduces the volume of CSF. Well, Goschel et al. Did a study on that, and they really felt that it may not aid in resolving CSF, traumatic CSF rhinorrhea, and it actually might be harmful. In the study, they looked at 44 head injury patients with CSF leaks, and they gave the diuretic to 21 patients, and to 23 patients, they gave nothing. And when they looked at the duration of CSF leaks, the group that received the diuretic took about 5 days for the CSF leak to stop, whereas in the other group, it took about 4 days. So very, very similar whether you had the diuretics or whether you didn't. In the group that got diuretics, they found that they had quite significant side effects like GIT upset, low levels of potassium, low levels of bicarbs. So it's certainly not a drug that is without risks or side effects. So if we move now to our surgical CSF leak repair options, as we mentioned before, there's been quite a big shift to endoscopic techniques over the last 30 years. The literature still describes intracranial repairs, and that's typically done by frontal craniotomy, and you can have a variety of flaps. You can have free flaps, periosteal flaps, dual flaps, muscle plugs, fibrin glue. The area that might be difficult with an intracranial repair is the sphenoid sinus. It might be difficult to access. The advantage of these intracranial repairs is that you can inspect the cerebral cortex, but the disadvantages are, in my opinion, really outweigh the advantages. The disadvantages are very high morbidity. Your patients have persistent anosmia. They can have seizures. They have much longer post-operative stay. There's a very high failure rate, up to 40% for your first attempt and a 10% overall. So intracranial repairs are falling more and more out of favor. Our endoscopic options, so that's where we come in. We've really got two broad categories. We've got transnasal endoscopic approaches, and we've got the combined approach. So if you have a look at these images that we've put out here, our transnasal endoscopic would be your image number 1. When we look at our combined approach in image 2A, that's where we've actually done a frontal sinusotomy and we're using an endoscope. And in image B, that's actually a transorbital approach with an endoscope. And these are combined endoscopic and external approaches. When we still look at some external approaches, there is a circumstance where if there's a defect in the posterior table of the frontal sinus, it's described in the literature as being quite a difficult area to repair. And this is really where that combined approach can help you. The combined approach that we opt for is where we do an eyebrow incision and you might do an extended trephination of the frontal sinus. But there are also other external approaches described in the literature with various incisions to basically gain access to ethmoid or sphenoid sinuses, such as external ethmoidectomy, transethmoidal sphenoidotomy, transeptal sphenoidotomies, just to name a few. But these external approaches are really infrequently used now because we have a very high success rate of endoscopic approaches. So it doesn't really make sense to cause significant morbidity in patients where we have a suitable alternative in the form of endoscopic approaches. General endoscopic concepts, perioperative, you can give a stat dose of IV antibiotics, although they are, as we mentioned, there's no randomized controlled trials. You want to decongest that nasal cavity. You want to put in some local into the axilla of the middle turbinate and the SBA region. Your anesthesia, some of the literature recommends propofol and remifentanil. That's results in a reduced heart rate. With regards to lumbar drains, as we mentioned, they have not been demonstrated to decrease recurrence rates, but the theory for lumbar drains is that they assume that the drain will reduce the CSF pressure on the repair site. So lumbar drains are very much institution and surgeon dependent. If you have lumbar drains, you can obviously use fluorescein, but the drawback is that you can have seizures. You need very special consent for if you're going to use fluorescein. Patients can have headaches, and obviously when you have a lumbar drain, you have reduced mobility whilst in hospital. When we look at endoscopic approaches, the advantage of this is that we have great field visualization. We've got some angle visualization because we've got different lenses that we can use. It allows you to have more accurate placement of grafts. We have an excellent success rate, a 90 to 95% success rate. You also manage to preserve a lot of the nasal bony framework. There are two scenarios that might present to be slightly more challenging when you use endoscopic approaches. The first is, as we mentioned, that lesion, when there's a lesion or defect in the posterior wall of the frontal sinus. So for that, you might need a combined approach. And the second one is really in the region of Sternberg's canal. And for that, you might need to use a transpterygoidal approach. And in this study that Tibi did, they felt that there was adequate exposure through the endonasal corridor and a very high successful closure rate when using a transpterygoidal approach to access Sternberg's canal. So when we look at frontal sinus CSF leaks, this is just to demonstrate the combined approach as well as the endoscopic approach. So it is minimally invasive. There's no need for obliteration of the sinus, and also there's no lumbar drain. So if you have a look at this, this is just a video where there's a repair of the defect in the posterior table using this combined approach. This is really what we describe as above and below approach. So I hope this video plays. So this is what we call above and below, or what we've termed an above and below approach. So just taking some of the bone, removing it, and then through the nose. And there you can actually see the other instrument popping through. Okay. This is our last video. That's just seeing the instrument coming from above. Okay, so with regards to endoscopic approaches, there are many different endoscopic approaches that are available to us, and they allow us to access our little area of interest in the most efficient fashion. So there are quite a few approaches. We won't discuss all of them, but if you were using a transfrontal approach, you really would want to have careful preservation of the frontal sinus outflow tract. You don't want a mucocele to develop in the area where you've operated. It also, endoscopically, it also helps to avoid obliteration of the frontal sinus with that traditional osteoplastic flap that was previously required. The defects in the most lateral or superior aspects, transfrontal can be tricky. And that's really limited by our current instrumentation, being able to look into different areas. So for a transfrontal approach, you may need to do first do an ethmoidectomy, identify the frontal recess. It needs to be widened with an endoscopic Lathrop or draft procedure, and then you can essentially have panoramic exposure of the posterior table. There are other endoscopic approaches like transcripiform, foveal, planum, and clival, which we won't go into, but they're just to know that these approaches are well described in the literature. And then one of the endoscopic approaches I did want to mention was the transpterygoidal approach. That's to access Sternberg's canal. So first, you would need to do an endoscopic modified medial maxillectomy. That should give you a really wide view of the lateral extent of the maxilla and the posterior wall of that maxillary sinus. You'll identify your infraorbital nerve. You'll do the sphenoethmoidectomy. You'll locate your crista ethmoidalis, and then you also want to locate the main branch of your SPA. At this point, you might want to raise a nasal septal flap, which I do have a little video coming up. You have to try to, if you are going to raise a flap, you really have to preserve your sphenopalatine artery and its proximal supply. If you're going to use a free mucosal graft, then you can cauterize the SPA. But whether you use a nasal septal flap or a free mucosal graft, The important thing is that the bone of the posterior wall of that maxillary sinus will need to be removed so that the SPA can be dissected proximally. You want to be able to identify the internal maxillary artery and all its ascending and descending branches. So the sphenopalatine artery is really an important landmark. It gives you an indicator of where your pterygopalatine ganglion will occur, and you really need to try to preserve this ganglion as well as the parasympathetic fibers. So once you've identified your maxillary artery and the parasympathetic fibers, the fat in the pterygopalatine fossa can be dissected, and then that gives you access to the lateral recess of the sphenoid sinus. Bone can be removed with a drill, and that will help with exposure of contents of that sphenoid sinus. So at Groote Hospital, our intraoperative considerations for our endoscopic endonasal approaches are really that we need good cooperation between our ENT surgeons and neurosurgeons. We need to clearly define what our anatomical defect is. You want to pre-measure the size of the defect. You may consider using a buttress. If we're going to use abdominal fat, we'll mix it in with Surgicel to make it a little bit easier to work with, so that it sort of sticks down a bit. We like multi-level closures. We do not believe in lumbar drains, or we don't commonly use lumbar drains. We do individualize our patients with graded approaches, and we should always be aware of patients with high BMIs that they are at risk for recurrence of CSF leak. So this is a typical patient that we would take to theatre. We have the benefit of having neuronavigation. So pre-operatively, we can set up the neuronavigation. You want the head in neutral. You'll ask the anaesthetist to put in an armored tube. We don't use throat packs. You can see in this image, you'll prepare the abdomen in case you want to harvest some fat. And then you'll prepare the nose, as we mentioned before, with nasal decongestants in the form of adrenaline. Intraoperatively, it's all about access and exposure of that defect. That will include your maxillary antrostomy, ethmoidectomy, frontal sinusotomy, and sphenoidectomy. If you have large defects, you may even need a posterior septectomy. So everything needs to be opened widely. Once you've isolated the defect, you may want to just double check that there's no encephalocele. If there is, then you'll resect it with bipolar cautery. You've got to be really careful when you resect it because you don't want to cause intracranial hemorrhage. And then you really have to try and clear up the mucosa around the defect because you don't want a recurrence of the mucocele. You should have a margin of around 2 to 5 millimeters of exposed bone. And at this point, you'll measure your defect and gain an impression of the size of graft or flap that you might need. Graft materials that we use at GSH, we can use free grafts such as fat, fascia, that might be temporalis or fascia lata. We also like free mucosal grafts. For our pedicle flaps, we have nasoseptal flaps or mucoperichondrial flaps that are based on your SPA. You can use a lateral nasal wall flap. You can also use the middle turbinate flap, and we sometimes use Durgen. So how do you decide on what graft you're going to use and the technique? It really depends on surgeon preference, experience, and expertise. So when you do place the graft, it often involves autogenous inlay of fascia lata, then followed by a rigid buttress. You could also have a vascularized nasal septal or middle turbinate flap for defects, and there's usually a final layer of Duracell. There are some other options with regards to graft types. You can use autologous fat over the intracranial dural surface. Bone grafts are also described for large defects. Typically, you'll do an underlay. You can take it from the septum or mastoid tip, for example. And then we do sequential application of autogenous and exogenous graft material. So it's a multi-layered approach. So this is just an example in this image of a nasoseptal pedicled flap. So as you can see, that's where the nasoseptal pedicle flap has been harvested from. It's being pushed posteriorly with great skill. And it's been put into an area that still is not in your way. It allows you to address the other areas, get hemostasis. And then at some point, we'll need to rotate this flap, make sure that it's not rotated on its pedicle. This is really just cleaning up. Okay. I hope I have another video. I think I have another one. So with regards to this nasoseptal flap, it's also known as the Haddad Basagastagai flap, and it's really based on the posterior septal artery from the sphenopalatine. Where you'll use this nasoseptal flap is if you have a pituitary CSF leak, that Sternberg canal defect. You can use it for the whole anterior skull base, even for reconstruction in areas where there's been clival chordomas. How do you choose the graft type? Well, Lee et al. Did an overlay versus an underlay study, and they found that the success rates were very similar, whether you used overlay or underlay. There was no real difference between the techniques, and doesn't really show to have to affect the success of the endoscopic repair. If you want to look at the size of the defect and gauge an idea of what graft you should be using, 2 to 5 millimeters, the literature says you can use a simple onlay of either mucosa or fascia. If there's a significant dural tear, you might want to consider composite graft. And in this case, you'll do a multi-layer closure with separate underlay and overlay grafts. If it's bigger than 5, you would also opt for composite grafting. Mucosal graft is generally an overlay. That can be freestanding or pedicle based. It can be, you can use septal mucosa or you can use the middle turbinate, as we've discussed before. If you're going to do a mucosal graft, you'll do 3 incisions, a vertical, superior horizontal, and inferior horizontal. Your flap needs to be attached posterior laterally, and that pedicle contains that sphenopalatine neurovascular bundle, and that's why it's quite important not to rotate the graft when you're placing it. Alternatively, you can use mucosal grafts such as alloderm. The grafts or flaps can be anchored with fibrin, and then they can be reinforced with gel foam, and you can apply some packing to apply pressure to the site. Critically, if you're going to use grafts or sealant, it must not obstruct the paranasal sinuses. So you must make sure that all your sinuses are widely open when you do the skull base repair. So this is really our steps at Groote Hospital. In this image, the first image or video is where just some surgery cell being removed. You can see that there's a very large CSF leak. So you can see in this image, this CSF leak is fairly easy to identify just because it's quite significant. Sorry. I just want to make sure we haven't missed one. Here we go. So this is the video that I wanted to show with the second step with elevating that mucoperichondrial flap. You can see a bit of local anesthetic going in there. Okay, then this is just an image of our abdominal fat being harvested and placed quite successfully. Popping in that fat, it's also mixed with a bit of surgery cell to make it easier to manage. Nice. Okay, and then this is where they've removed a bit of cartilage from the septum after the fat has been placed. This is the buttress flap. Technically quite challenging, but you'll see in a minute that this one pops in very nicely. And that's the last piece of cartilage. So again, a multi-layered closure. And then we can add some Duracell. And that seems to have held. Okay. So at GSH, we like a graded approach. We like to identify the site that has the leak. We will then put abdominal fat that's mixed with Surgicel. We will harvest cartilage and do a buttress repair. You then can do you may do a Duragen underlay. You might do a mucoperichondral flap overlay. You might put some fat or Surgicel to try and hold it. You'll apply some Duracell and then Surgiflow, and lastly, you'll apply rapid rhino to the nasal cavity. When you're trying to wake the patient, it's important that you shouldn't do positive pressure bagging. That should be avoided. Post-operatively, we don't do lumbar drains, but if you did have a lumbar drain, you would check the lumbar drain, should be around, keep it in for around 48 hours, at which point it's clamped for 6 hours. And if the opening pressure is very high, then you might need to consider diuretics. We follow them up for non-absorbable packing that can be removed in 7 to 10 days. You will follow them up with endoscopic examination. At every interaction, you will always check for signs of rage, intracranial pressure. If you're using a diuretic, check your electrolytes. And then always, if you have significant side effects, you might consider a shunt, but that's also very rarely. I don't think we ever really see that. What are the controversies? Well, as mentioned, the controversies are really with regards to the lumbar drain. There's no prospective randomized control trials on it to show that it actually has an effect on the recurrence rate after the repair. The second one is the use of the diuretic and the VP shunting. And the last controversy is really with regard to prophylactic antibiotics, as we have mentioned before. There's no conclusive studies on whether or not it reduces meningitis. In conclusion, our endoscopic endonasal approach is a safe procedure. It is very effective to repair CSF leaks. It has equivalent success rates to open procedures, if not better. It can significantly lower the rates of post-operative complications in comparison to open repairs, and there's a very low perioperative mortality rate. Thanks very much.
Excellent. Thanks so much, Louisa. We would like to welcome Raouf Aladat, our past rhinology fellow, to just help with questions. So I'm going to kick right off with a question from Rohit Stephen, is how to differentiate between high pressure leaks and low pressure leaks. Louisa or Raouf, I don't know if you would like to answer this question.
Usually, when the patient's actively leaking, it's difficult to measure them. So the only way you can measure the high intracranial pressure is after repair them and then refer them to a neuromedicine to check the opening pressure. Before that, it's usually difficult. For those patients with high intracranial pressure, usually female, middle-aged, with high PMI, those patients usually we refer them to ophthalmology to check the optic nerve and to check the visual acuity. And then after post-op, we have to refer them back because those patients that are high risk of visual loss, and then they might need optic nerve decompression or shunting or something like that. But it's difficult to measure when they are leaking.
And then, Raouf, would we give Niemovac to all of these patients?
I think Raphael, he must answer this question.
Raphael, would you like to answer this question? Okay, Raphael is not on the line now.
Yeah, yes, always we give it because if they got the streptococcal pneumonia, it's a matter of hours. So they might patient they might get bad meningitis and might die within 6 hours. So it's crucial to give them a pneumovac. All of our patients, we give them a pneumovac.
And Raouf, are there any steps and precautions taken to preserve the function of smell during a nasoseptal flap?
So it's important just not to go high up. So what we do the inferior margin of the middle turbinate. It's our upper landmark. So we don't go above it, and then down you could take the whole floor of the nose, and then you can go up to the lateral wall, and then anterior you can go up to the hemitransfixion incision. So you can really take a huge flap, but most important, don't go above the middle turbinate, the lower margin of the middle turbinate.
And then another question is how long to leave packs for? The question from Suli is, do you leave your non-absorbable nasal packs in for 7 to 10 days?
So we keep just one like rubber drying pack for 1 or 2 days, just to prevent the patient to blow their nose immediately post-op, and then we leave the Duracell and everything until about 1 week or 2 weeks post-op, and then we try not to clean the nose, and we ask the patient to clean to flush the nose with themselves, and then when we make sure that the flap has been taken, then we clean it. Before that, we try not to touch it.
Thank you so much, Raouf. I would like to ask if Kafui Siario is on the call, and I would like to ask him if he's got any experience with anterior skull base CSF leaks repair in Ghana, since he's completed his skull base rhinology fellowship with Prof. Lubber. If not, maybe Kenneth can give a few inputs from what he's seen or see Kafui do. Okay, so it doesn't look like Kafui is on the call. Is there any other questions or comments? Anyone who would like to raise a hand?
One more comment, Farid. Patient had history of seizure pre-op. Those patients, they are at very high risk of getting seizure post-op. Those patients, sometimes we load them intra-op, and we give them at least one month of anti-epileptic medication. I think it's very important.
Okay. Prof, would you like to give any comments?
Yeah, just to say I think it was it was really an excellent presentation and a summary, and also just to remind people that in the setting of head trauma, that you shouldn't forget that the middle fossa or posterior fossa fracture with a leak in the middle ear can present with CSF leaks in the nose. So when you're trying to locate your fracture, don't forget about that as being a possible origin of a CSF anterior leak.
And then Raouf, I just saw a very important question from Neville Bonku. And he asks, for iatrogenic leaks discovered post-op, is there any place for a trial of conservative management? So would we take these patients back to theatre immediately, or would we wait a few days and see if it resolves spontaneously?
I think what we do, because all the evidence says that the chance of recovery spontaneously is very low, so we take all of them back to theatre.
Okay. Excellent. And then I just want to see if there's any raised hands. Thanks to everyone who have joined this morning. We've reached our time for this morning. We just thank you again to Louisa Brown now, who presented. And we would like to remind everyone of our case presentations this coming Friday at 8:30. So we hope to see you there. Have a good week. Thank you.